Welcome to everyone who joins us, and thank you for joining us today for our third session in our speaker series. Today's session is Making Your Wishes Known, Difficult Conversations about End of Life. And this 5-part series hosted by LifePath and the Community Hospice in partnership with the Albany Guardian Society has been an exciting endeavor aimed to help us better understand our emotions as part of life and love. Felicia Segelkin of LifePath and myself, Kristen Vivian from the Community Hospice, are your moderators, and we are glad to be here today with all of you, our guests, and our speakers today. A couple of housekeeping items. As you've heard Felicia mention, please keep yourselves muted and your cameras off. We invite you to use the chat box for any questions that might come up during the presentation. There will be time at the end of the presentation for our panelists to address the questions and answer them for you and make responses. A resource listing was provided to you with your registration, so please be sure to take a look at that. There are some valuable resources listed for your benefit. And after this presentation, the slides will be provided to you, the attendees. We are being recorded today, and a link to the recording should be available in the coming weeks. The first 2 sessions of the series, if you've been unable to hear them thus far, are available in recorded form on the LifePath website. So please be sure to listen to those if you haven't had the opportunity to do so. They were full of good information. And I will also just mention that if you are unfamiliar with the chat box, you would simply take your cursor and bring it to the bottom of the screen where a menu will pop up and you will see a chat. You would click on chat and a box of dialogue would open up, and you could type a message. It says type message here. Be sure that the message is directed to everyone, and then just simply hit enter once you have finished typing your message into the space. And so I will go ahead and turn the mic over to Felicia, who will introduce our wonderful speakers for today, and thank you again for joining us. We do hope that you will join us again in the beginning of November and December for the 4th and 5th sessions of this series. Thank you.
Thank you, Kristen. So yes, I will be introducing all the 3 speakers with us today. The first one being Gwendolyn Bondi, who holds a Master's of Science in Bioethics from the Icahn School of Medicine at Mount Sinai and Union Graduate College. She believes that good planning is likely to result in a good outcome and has dedicated her professional life to guiding people towards the tools they need to ensure that they are cared for in the way that they want to be. Gwen provides her bioethicist training to everything that she does, from advanced directives to ways to start those difficult conversations. Gwen has been published many times regarding her pioneering work in the Capital District. Dr. George Giokis is a physician specializing in the care of patients with serious illnesses. He completed his undergraduate degree from Tufts University, his medical degree from George Washington University, and his internal medicine residency at the Albany Medical Center. Dr. Giokis has practiced primary care internal medicine for 25 years before focusing on palliative medicine. He has developed the palliative care program of the Community Hospice, St. Peter's Health Partners, and Ellis Medicine. And in addition to his clinical responsibility, he remains active in the education of clinicians and the community on palliative medicine and end-of-life care. Last but certainly not least is Emily Nicky, who is a case manager with the Alzheimer's Center of Albany Medical Center. She has received her bachelor's in arts in psychology from Siena College and her master's in social work from the University at Albany through the Internships in Aging program. Emily previously interned for the Eddie Alzheimer's Services. She has experience working with individuals and families affected by the Alzheimer's disease and other dementias. She also provides support and education and connects those who with the needs-based services in the area. And with that, I would like to pass it off to our speakers today.
Thank you. Next slide, please. So why is this important? And essentially, most important is to ensure that you receive the care according to your wishes and your values. And the phrase that comes from the Conversation Project, which is an excellent resource which we encourage you to go to, is to remind us that it's too early until it's too late. And I think we can all recount from our own personal or friends' experiences of unexpected emergencies that have occurred, whether they're things like car accidents or falls in the winter with ice and a hip fracture or head trauma, or an unexpected health emergency, the new diagnosis of cancer or heart disease or something like that. And people think best when we're not in the midst of a crisis. So it's best to pre-plan. It's also important to understand, because many people will say, well, I'll just deal with it when it occurs. But you need to understand that when you have a serious health issue, even one that does not affect your brain, so we're talking about a heart attack or a serious infection where the brain's not involved, the brain does not function as effectively in the midst of a serious illness. There's a specific term called metabolic encephalopathy, but you're not going to be thinking clearly, not because of just the overwhelming stress, and it will be stressful psychologically, but physiologically. What's happening physical to the processes of your brain is affected by other parts of your body. And the other stressor, quite honestly, is that the physician, if you have a trusted physician or care provider in the community, what's happened over the last few decades is that community physicians are really community-based. And now we have a separate, excellent group of full-time hospital-based doctors. So you'll be likely being taken care of by a hospitalist or a critical care physician, someone you may have not ever met before, or your family may not have ever met before. And that's very important to understand. Now, yes, they will reach out to your community-based physician, but the sense that, well, Dr. So-and-so knows what to do, he knows my wishes and values, that connection is not as tight as it used to be. And finally, not only the impact on yourself, this affects families. And I think, again, you can probably draw on stories of your families or friends where there was suddenly a health emergency, where maybe the individual couldn't speak for themselves. And now family members, though they're loving and caring, they have different ideas of what should be done, and that can cause stress within the family. So it's important not only for yourself, but also the impact it's going to have on your family. And again, these things occur, unfortunately, unexpectedly. So next slide, and I'll send it over to Gwendolyn.
Thank you. So what to talk about? I'd first just like to say that advanced care planning involves several things. First of all, thinking about your future healthcare decisions, but also talking about those decisions. And in thinking and talking about those items, you would want to consider several important things. First of all, who would make healthcare decisions for you if you could not express them yourself? And then how could you make those wishes known? After all, you're going to be putting some thought into this. You want to have meaningful conversations, and you want those wishes carried out. So we'll talk about that in subsequent slides. But as Dr. Jokas mentioned, sometimes the illness or the condition you find yourself in is sudden. And so advanced care planning is very important to have something in place before that sudden event happens. When we're talking about these things, you want to begin with a personal reflection, and you'll hear the phrase, what matters most? So think about what matters most to you. This will be a very individual decision, and not just decision, but things that may change in your life about what matters most to you as your circumstances change. Think about what's shaped your feelings about medical treatment and your experiences. You may have experiences you've faced with loved ones where the treatment or the outcome was not quite what you might have expected. There may be times you think to yourself that those experiences might have been handled a little bit differently. So your personal experience is very important there. Think about what goals you have for both short-term and long-term as you're facing an illness or you find yourself in an illness. And then finally, will medical treatment help or hinder reaching those goals? It will be very important for you to learn about the benefits and the burdens of treatment options. And one way that you might do that is to speak with your physician, other healthcare professionals, to understand those benefits and burdens. And, as you know those things, that may help to form your opinion about what treatments you might like in the future. It should lead to a conversation. Next slide, please. So setting the stage for a conversation is very important. I'll go down through each of these bullet points just to help to illustrate how to begin. Think about who you want to talk to, who you would want to share your concerns about your future healthcare is important. Think about who would be open to having a conversation and who you are most comfortable with speaking about those very personal, intimate things. Also consider, when would it be a good time to talk? Usually, advanced care planning in the term advance indicates that you should do it before any event happens. That's the key to advanced care planning. But when would you do this? Dr. Bamba, who is the foremost authority on MOLST, which is Medical Orders for Life-Sustaining Treatment in New York State, often has this conversation every year at Thanksgiving when her family gathers. That might be a good time for your family. It might not be such a good time for your family. But think about when people are around and you'd like to share that information. Also, where would you feel comfortable talking about these things? As for me and my family, we've had lots of little short conversations, 5 minutes long, while we're walking the dog. And an idea just pops into my head and we start talking about it. That little bit of information plants a seed in the person I'm walking with, usually one of my adult children or my husband. And, the next time we walk the dog, we have another little conversation. So repetition is important as well. And then what do you want to be sure to say? Think about 3 most important things you'd like your friends, family, or doctors to understand about your wishes and preferences for end-of-life care. Next slide, please. And then how to start the conversation. This is often the hardest part, just to start talking about some of the things that are important to you. So I provided on this slide just a few items that are in the conversation project. as recommendations. So even though I'm okay right now, I'm worried that such and such, and I want to be prepared. Will you help me with that? Can we talk about that? Or here's another idea. I need to think about the future. Will you help me? They have no idea what you might be talking about when you say something like that, but it's a good segue to just start the conversation. And then the last example I have, there are many more examples, but this one is, I was thinking about what happened to Aunt Mary, and it made me realize I'm not sure I want the type of treatment that she had, et cetera, et cetera. Make it up as you go. I mean, it could be very hypothetical. There are also a few examples on the conversation project at the links below. Next slide, please. And then finally, what to talk about. So think about, who do you want or not want to be involved in your care? In my experience, sometimes a spouse does not want their spouse to be involved in decision making, simply because they know they're unlikely to follow your directions for treatment. It can be anyone you choose, anyone that you are comfortable with, and who you trust, and who is willing to be involved with your future care. Think about if you would prefer to be actively involved in decisions about your care. Some people prefer that their doctors do what they think is best and provide that permission and respect that advice. Again, it's totally up to you as an individual. Are there any disagreements or family tensions that you're concerned about? Talk about that. Think about it with yourself. But if you select someone to be your healthcare agent or your spokesperson who can help manage some of the decision making, and you know that there are already some family tensions or disagreements that might erupt in the family, it would be very smart to talk about that with the rest of the family members, to tell them why you selected, one adult child over another to help make those decisions, or why you selected a family friend to help make those decisions. Once they understand your reasoning, you can sort of diffuse some of those tensions that might arise later when it's a very emotional time and decisions need to be made. Are there important milestones you'd like to be there for? This next point is very important. How aggressive would you want your treatment to be if you could not return to your previous quality of life? And how will your healthcare agent know when it's enough? Very important. Think about that. Communicate that, and let your physicians know also in your healthcare proxy, in your advance directive, in your MOLST, what have you. And would you want life-sustaining treatment to keep you alive, even if you were not expected to return to the quality of life you cherish? I'll just leave that last one for you to ponder. These are difficult questions and serious things to think about, but remember, it's your choice. Based on your experiences and your beliefs, your wants and desires. Next slide, please.
Okay, so as you can imagine, there are factors that make advanced care planning more difficult. Dr. Gioka has kind of started to mention these, so we'll go into a few. So what happens when it becomes too late? So dementia is just one example of a disease that can impact an individual's ability to make decisions about their own care. There are lots, but this is just one that I specialize in, so bear with me. There are different types of dementia, and each can impact decision-making differently. As you can see in the graphic, dementia is the umbrella term used for all these different types of dementia. And they go through stages. So the different stages, things like mild, moderate, and severe stages. Someone in a mild stage could have all the decision-making capability in the world. As they progress, because this is a permanent progressive neurodegenerative disease, it becomes harder and it becomes more difficult for the person to vocalize, if they're even able to vocalize their wishes. And this is extremely important for the family as well as the individual. Next slide, please. So why is it especially important in this case to have advanced care planning earlier rather than later? And the answer is, as an individual moves through this disease, it can become increasingly difficult. And this can be compared to things like cancer or heart disease, things like that. Dementia is terminal, as well as our other diseases that you see, but one thing that we think about in advanced care planning is, oh, I'll get to it when I'm older. I'll get to it when, my kids are adults. I'll get to it when my grandchildren can be involved. But this is something that may impact. It's not a normal part of aging. So it's important to know that to do these before you get to this point. Go to the next slide, please. So now we're going to kind of talk about the different methods of advanced care planning. So we'll go into a few. This is just a good graphic that kind of shows the difference between a living will and a healthcare proxy. One of the most common questions I get from my clients and my families is, well, can I have one without the other? What's the difference between them? Don't they do the same thing? So a living will is a document that contains your healthcare wishes, and it's addressed to unnamed family, friends, or hospitals or other healthcare facilities. You can use this to specify your wishes about life-prolonging procedures and other end-of-life care so that your specific instructions can be read by your caregivers when you're unable to communicate your wishes. This leads into how this is different from the healthcare proxy, which is a document that actually allows you to appoint a person or persons as your healthcare agent to make your healthcare decisions on your behalf if you're no longer able to do so. You may give your healthcare agent authority to make decisions for all in your medical situations if you cannot speak for yourself. Thus, even in medical situations that are not anticipated, your agent can make decisions according to your wishes, values, and beliefs. Can go to the next slide, please. So going more into the differences between them, kind of speaking about what makes them so different. The healthcare proxy you should really think of as the WHO of advanced care directives. So this is where you share your wishes for end-of-life care can bring you closer to the people you love. It's kind of a speculation that talking about things like death and end of life, our culture in Western culture really doesn't like to do that. So sometimes people say, well, if I start talking about death, someone's going to think that I'm suicidal or thinking about, the end of my life and I'm not here in the present. But it actually can bring you closer to the people in your life and showing them that you want them to be involved. It is critically important, and you can do it. One conversation can make all the difference. As Gwen did a great job explaining how to go into these conversations, these are so important to have with your family and loved one. And it doesn't have to be, your spouse or your children. It can be someone who you trust. Just starting the conversation with your who's is really important. Select someone whom you trust to talk with and discuss your values and goals. This is extremely important. Don't just select someone who you think, is closest to you or, can make a decision in crisis. It's really important that this person knows who you are at your core in terms of your values and goals, not just what you would want in terms of medical procedures, but what you would want in terms of your life. This person should be willing to accept the responsibility for expressing your wishes. This is also very important. This person should be able to take this role. If you select someone or start to have the conversations and they openly say to you, I'm not comfortable making these decisions, that's okay for them to say that as well. You know, there is not an obligation for your children or, you know, the people around you to make those decisions. You know, they have the right to say, I don't think that I could make those decisions. And you want someone who would be able to make the decisions on your behalf rather than what they would want for you. Make sure they understand that they will be following your instructions. So a big part of this is you are going to be appointing the person to follow along wishes that you already have in place. So make sure they understand that. As Gwen had mentioned, have these conversations multiple times. You know, this is not a finalized document, and you know what you decide when you're in your 30s is end all be all. You know, it can change as you age, especially for things like terminal illness or, you know, illness in the family or death of a loved one. This is an ongoing process. It should be very fluid. And make sure they're able to make these decisions in stressful situations. These advanced care planning, as we mentioned, should be advanced. But, you know, a lot of times when someone gets sick or someone is ill, it can cause crisis. It can cause our fight or flight kind of mentality. So make sure that they're able to follow through with your decisions if something actually were to happen to you. The link on the bottom is just kind of a more specified video of the healthcare proxy, the WHO. It goes through some silly examples, but it's a really good visualization if you have time to go through it. Next slide, please. So this is what the actual healthcare proxy form looks like in New York State, and I've included the link below it. What's important to know about the healthcare proxy form is this does not need to be notarized or completed by a lawyer. You could really pull this out, as we've been talking about, at Thanksgiving dinner and say, we are going to follow this, and this is what I want. This is who I need, you know, in charge. And, you know, this is something that you just have to make sure that is signed and dated. As you can see, there are witnesses. You know, the witness just can't be the person you choose, you know, and vice versa. So, you know, remember that this form, you should have had a conversation about it before. Don't just bring this up to someone and say, hey, you're my healthcare proxy, because nobody, you know, you don't want to shock someone with that. But it can be found on the New York State website. And again, like we kind of mentioned, this is a fluid process. You can redo this at any point. This is not something that gets, you know, signed and dated by New York State, and that's what you have to stick with. This is something that, you know, in my family, we do every 5 or 10 years just to kind of, I have one, I'm only 25. So, you know, it's something that can be updated as your wishes change, especially if there is a death of a loved one or a death of a spouse. You want to make sure that this is updated, that your who is updated. You can go to the next slide. And then we get more into the what. So the living will, this is a set of instructions providing the clear and convincing evidence for treatment. So this kind of, you know, going along with the healthcare proxy, these are really your wishes. One important thing to note is keep your instructions specific. You know, if instructions are too vague, you know, provide a more precise example. The example here is, if I reach a point where it is reasonably certain I will not recover to my ability to know who I am, who I am with, I want to stop or withhold treatments that might be used to prolong my life. It's very important to be specific in these wishes. You don't want to leave things unknown if there is a specific wish. But you can also decide what's binding on the healthcare agent. So kind of be specific. You can also leave it up to your healthcare proxy or the people involved in your care, how much latitude you'd want them to have at the end of the day. So do you believe that they would have your best interest at mind? You know, if you were not able to make that decision, it's okay to leave that on them, but make sure that they know that they're responsible for that decision. All right, next slide, please. And we're just going to go into a few examples of what happens if I don't have these plans in place. Some people are under the impression that these topics might be too sad or too much of a burden to place responsibility on a loved one. It's very common. You know, that's one of the things that I get most of the time with my families and my clients is, well, I don't want to talk about it because I don't want to make them sad. It's actually been seen to cause even more stress and issues among families who are not at least verbal in what they want done. It can cause strenuous relationships. It can cause conflict among the family. You know, if you have 5 children and all of them think they're in charge, for example, it could be really difficult. It's also okay to leave things up to the doctor. If you trust a healthcare professional to make those decisions for you, that's okay too. Another important thing to mention, especially with some of the clients that I deal with in terms of progressing through the disease of dementia, is the concept of guardianship. So this is a little more extreme. This is if there's no family or loved ones involved. It can also be a lengthy process. This can either involve a friend or family member claiming guardianship over someone who is not capable of making their own decisions, whether that be healthcare, financial, but in this case, it would be more healthcare. It can also be done by the state, so APS, if it's a dangerous or unsafe situation. But this is really a last-ditch effort. We really like to get any family that we can involved with someone's care so that you don't have to claim guardianship. And next slide, please. Dr. G, you are muted.
Thank you for reminding me. So I do that so often. So again, what do we do if these aren't in place? I wanted to talk a little bit first about leaving it up to the doctor, as a doctor who sometimes is in these situations. What I would recommend is to let your families know, I really want you to trust the doctor's decision if that's what you want. The doctor is unable to stop treatments, life-sustaining treatments specifically, unless the physician knows that either those treatments are clearly futile, and futile, and in New York State, that meets a very, very high standard, meaning no likelihood that it will sustain life in the short term, meaning days or a short period of time, a very short period of time, or unless the physician knows the patient's value. So it may not be written down, but if families or friends can say, listen, we have, and there's a legal term, clear and convincing evidence. We know, we've had repeated conversations. He hasn't completed a document, but we've had repeated conversations, and this is most important in this person's life. Then the physician can make a recommendation. What I can do, these medical treatments, unfortunately, are not going to attain the goals, the quality of life that this person will want. But if a physician is actually in the role of a healthcare agent, because there have been times people say, well, I trust my physician, I also want him or her to be my healthcare agent, then they can not also be your attending doctor. A doctor can either be your attending doctor, meaning in charge of your care, or your healthcare agent, but you can't occupy, a doctor can't occupy both spaces at the same time. Separate from that situation, the more common situation is we may have a critically ill individual who cannot communicate their wishes or think thoroughly, and have not documented a healthcare agent and don't have a living will. So New York State, and this does vary from state to state, but in New York State, the Family Healthcare Decision Act says that in the absence of a healthcare agent or other clear and convincing evidence, there's that state phrase again, of the patient's wishes, then we would first go to a court-appointed guardian, though most individuals don't have court-appointed guardians, and it can take months, literally months, to appoint a court-appointed guardian. Then we would go to the patient's spouse, the person's spouse, unless they're legally separated, or it could be their domestic partner. So if two people have a committed relationship, even though they're not legally married, but they clearly have a committed relationship, they live together, they share expenses, that person would be first on the list. It's a hierarchy. If that individual either is not available or doesn't want to take on that responsibility, then it would go to an adult child. It's not the oldest child, that's a frequent misconception. It's any adult child. And the standard for each of these is not what they would want, but their representation of what they feel the patient would want. And it was constructed in this way. New York State constructed it in this way with the sense that in descending order, these people know best what the patient would want because they're closest to the patient. And as Gwendolyn and Emily say, you want to avoid, well, this adult child says this adult child says that, who's going to be the decision maker? Hospitals and nursing homes have ethics committees that can help to try to resolve those issues. Palliative care teams also are involved to help resolve those issues, but you want to avoid those if you can. And then it would go to a parent. If an adult child was not available, then a sibling or a close friend. A close friend could represent themselves and say, these others are not available, but I know this person. I know this person's wishes. It's important to understand that if you're higher on the list, you can't appoint somebody lower on the list. So for example, a domestic partner could not say, well, I want to appoint I'm not willing to do this, but I want the parent. I want to skip the adult children. All you can say is, I'm willing to take that responsibility or not willing to take that responsibility. Then it would go to the next person in line. Next slide, please. So there's another document in New York State, and this is also, the paradigm is called PULSE for Physicians' Orders of Life-Sustaining Treatment. It's across all the United States, but specifically in New York State, it's called MOLST. It's a very bright pink form. Unlike the healthcare proxy and the living will, it is actually a doctor's order. And it's important, and I think I'll talk about this at another slide, that a healthcare proxy and a living will gives us an indication as physicians of what the patient wants, but it's not a documented order. It's primarily indicated for people with advanced chronic illness, a life expectancy of 1 year or less, or generally people who reside in long-term care facilities. It's not restricted to those individuals. So if you have very strong opinions, for example, you always want to attempt cardiac resuscitation no matter what, or you don't ever want to have cardiac resuscitation no matter what, even if you don't have an advanced illness, you don't have a life expectancy. Maybe in that situation you could have a MOLST, but it's primarily intended for individuals with those three conditions or characteristics. And it can indicate either to have things or not to have things done. Next slide, please. So again, the healthcare proxy is the who, the living will is the what, and it's important again is these are, the reason they're called advance is if in the future this occurs, I'm trying to think of what would happen in the future. In the future, what would I like? While the medical orders for life-sustaining treatment is as soon as it's signed by a physician, and it has to be signed by a physician, nurse practitioner, or physician assistant, that order is in place. So it's very important. Many people will say, well, a MOLST isn't actually an advance directive because once it's signed, it's in place. So it's important to understand the differences between these documents. Next line, or slide, I'm sorry. So this is what the MOLST actually looks like. It's a 4-page form. It's in pink. I believe we also have the link to this so you can download this. But again, it needs to be signed by a physician. It's a New York State Health Department form. The first page of the form, Section A, specifically and only speaks about what to do if your heart stops. And that's what we call resuscitation, cardiac resuscitation or CPR. First, please understand that in New York State, and essentially across the United States, if you don't have an advance directive, if you don't have a MOLST, our default position as nurses, physicians, is we're going to try to sustain your life. So if your heart stops, we're going to do CPR. And in most situations, that is most appropriate. However, there are situations where even attempting CPR has no reasonable chance of working, especially with someone with an advanced chronic illness, advanced cancer, advanced heart disease, advanced emphysema. It's unlikely that even if we attempt CPR, that it's going to be successful either number one, in that the person will survive the resuscitation attempt, or that they'll be well enough where they'll be able to eventually leave the hospital. Here are some just general statistics, and these are just general statistics. If you're an adult hospitalized in the United States and you have a cardiac arrest in the hospital, even with all of our the staff there, we're immediately there. There's only about a 25 or 30% chance that you're going to survive that resuscitation and eventually be able to leave the hospital. On the TV shows, it's always a lot different. The next day, people are up and around and they're walking around. But in reality, and again, to be in the hospital nowadays, you have to be pretty sick. So it's a selected group of individuals who are in the hospital and then have a cardiac arrest in the hospital. But again, it's only about a 30% chance that even with what we can do, we're going to be able to have you be able to eventually leave the hospital. If you're a frail elder, having difficulty taking care of yourself, doing getting up and around, spending most of the day in a chair or in bed, and you have a cardiac arrest in the community, there's less than a 5% chance that you'll survive even with it. So we talk about attempting CPR as the phrase. And again, this has to be signed by a doctor. It can be a decision by the patient, or if the patient doesn't have capacity to make decisions, then it would be a decision by their designated healthcare agent. Next, please. Next slide. Oh, so there's a close-up on that section A, whether to attempt CPR or not to attempt CPR. And again, if you don't have one of these forms, we are going to try to resuscitate you fully. Second page. The second page is much more complicated, and I won't go through them individually. I'd be happy to respond to questions later. But the talks about whether or not you'd want to be on a mechanical ventilator, meaning an artificial breathing machine where there's a tube inserted from your mouth or your nose down into your lungs, and the machine is breathing for you. Whether or not you would want to have a feeding tube, a tube inserted into from your nose into your stomach, or possibly directly into your stomach. What about future hospitalizations? Are you someone who would say, if something happened, I'd want to come right back to the hospital in the emergency room because I'd want to try and figure out exactly what's happening? Or are you someone would say, listen, I'm at a point now where I'd rather be taken care of at home, or if you're in a nursing home or assisted living, where I'm at is most important. I don't want to keep on going back and forth to the hospital. Use of antibiotics. So these are among the things that can be discussed. And again, it's an order that would be signed by a physician. There's a term that frequently comes in there called a trial period. Trial period is not a specific amount of time. It doesn't, by definition, it's not 3 days or 1 week or 2 weeks. The intent of a trial period, meaning I would like a trial period of being on a ventilator, says, yes, put me on the ventilator. I'm hoping I'm going to get better. But if I'm not making the progress that's defined in my healthcare, my living will, or as represented by my healthcare agent or family as to what my goals would be, I don't want to be stuck on a ventilator. While there's another part, because there are some people who would say, no matter what, as long as my heart's beating, I want to be on an artificial breathing machine. Or no matter what, doesn't matter how I'm interacting with people or whatever. If I'm not eating, I want a feeding tube in no matter what, long term. While other people might say, give it a try for a period of time, but if I'm not making the improvement you're hoping for, I don't want to be stuck in that situation. So that's the term trial period. It's not a specific amount of time, but are you making progress the way we hope? Next slide. So again, this term, what makes life living for you? What are your hopes? What are your concerns? And because in reality, many of the diseases that we develop as adults are progressive. Emily mentioned that dementia is a progressive disease. COPD or emphysema is a progressive disease. There's progressive lung deterioration, and with that, progressive limitation in a person's ability. Congestive heart failure is a progressive disease. And so over time, and as Gwendolyn said, these are why we want you to have repeated discussions with your family members. What trade-offs are you willing to make? There are many people who would say, if I have to be in a nursing home, that's not something I would want. But then there are other people who would say, or maybe even that same person years later might say, you know what? I'm getting care in the nursing home. I like where I am. I thought I never wanted to be not in my home, but I'm getting good care. I'm able to have visits with my family. You know, that's a trade-off I'm willing to make. I may not have wanted to have that trade-off years ago, but I'm willing to make that trade-off now. Or conversely, when I had cancer, when I was first diagnosed with cancer, I wanted to have everything. I wanted all the tests and chemotherapy and going back and forth to the doctor's office multiple times a week. But now it's 2 or 3 years later, and you know, I'm sort of getting sick of going back and forth and getting tests and treatments. So again, what are those trade-offs you're willing to make? And again, it may change in time. My sense, my soapbox, I'm sorry, it's a soapbox on my part, is I think the best system is where the patient or their representative or surrogate can say, this is what makes life living for this person, what matters most to them. And then their physician, and you're likely going to be dealing with multiple doctors probably, can say, well, knowing that, here are the treatments that more will give you the best chance of achieving that, or I'm sorry, even if we do these things, we're not going to be able to meet those goals that you want. That's why it's so important. This phrase of what matters most to you is so important. And those goals of, I think many of us are hoping we're going to live longer and independently, but we may get to a point where we're going to have to accept living longer, but with a level of dependence on others or machines or multiple medicines, or we might not be able to extend your life appreciably, but can we live the remainder of life you have as you want to live that life? Next slide, please. So in summing up, I hope we're on time. We're still on time. Number one, we want you to think about these take-home points. It's too early until it's too late. Please don't wait for the crisis. It's not good for you. It's not good for your family. Advanced care planning will help you and your family. Who do you trust to make that decision? Who's a good level thinker? Who knows what's most important to you? And then the what would you want? I'll give you some personal soapbox on this one as well. I'm a physician who's trained in serious illness, but even for me, trying to predict the future is very, very difficult. So I would suggest the what be not what treatments you want, being on a machine, being on dialysis, having a feeding tube. The what should be what's most important in your life. What are the goals and the values? That's what we need to know. And then hopefully a good medical system will be able to give you a sense, or your family a sense of, can we achieve that with everything we can do? We talked many times about revisiting these discussions. It's not a one and done. And then medical orders, that MOLS form, if you're in that situation where you have an advanced chronic illness, or you may only have a year or so of life left, or you're already significantly debilitated in a nursing home, you really should have those in place in addition to those advanced directives. You need both in place when you're at an advanced illness. So I think we've come to the conclusion of our prepared talks, Kristen, and yeah, so we'll turn it back to you and to the audience.
Well, thank you all for all of this information. I know we did have some questions coming in as you were all talking, so I'll just kind of start it off and then I'll let either all of you answer it or someone jump in. So the first one, going back to the healthcare proxy, someone had asked, how often should the healthcare proxy be updated?
I can address that. It's your choice. It can be updated at any time if your circumstances change or the people in your life change. But I would say at minimum, somewhere between 5 and 10 years is a good time to revisit it, revise it, update it. Things in your life change, and things that matter most to you change. Once you do that, the new one takes effect. The old one, as long as it's well distributed between your medical team and your healthcare proxy, your agent, and other people in your life, it serves as clear and convincing evidence of the path you've taken, actually, as a history of decision making as your life has progressed.
Can I add to that, to something Gwendolyn said, which is so important, is as it's distributed. So when you do complete these documents, share them, not only with your family members, but with your physician, and I'll put a S, physicians. Most people, or many health systems, have private medical records or digitized, computerized medical records. Bring it to your doctor's office, have it scanned, so that if there's an emergency, the hospital or whomever or your physician can access that medical record. I mean, just today I was meeting with a family and they said, well, it's in a safe deposit box and they're not sure they can get to it. And hopefully that living will, if people have taken the time to complete it, it's important that it's accessible when it's needed. There are times we have to, as physicians, I work primarily in a hospital nowadays, we have to call the lawyer's office if we can know who was the lawyer who completed it. Many of these documents are completed by the legal profession, not nurses or doctors, but then we'll ask with the family's permission, the legal profession to fax us a copy. So please distribute it to your doctors, to the hospital, have it as part of your medical record.
Great, thank you. I know there was another just follow-up question to the healthcare proxy form. Someone had said, and Gwen, you might have been alluding to this as well, that the New York State Department of Health has a 4-page updated healthcare proxy.
Well, the New York State healthcare proxy is 2 pages. The MOLST form is 4 pages. Along with the healthcare proxy, though, if you go onto the New York State website, there are lots of instructions. So there are, and explanations. So there are multiple pages there, but the actual form of a healthcare proxy is just 2 pages.
I think, Dr. Jokas, going back to something you just said, is a good segue into one of the questions that was asked, knowing that the expense of attorneys for people to compile these documents. Is there a way to do a living will without an attorney? I know that Gwen mentioned the healthcare proxy can be done just by an individual. It doesn't have to be witnessed or co-signed or anything, but the living will, is there any way to do that without an attorney?
Yes, there are living wills that are available, and you can download online. It needs to be witnessed, but again, not notarized. I think some of the important elements in a living will would be, as mentioned by Emily and Gwendolyn, is to what extent do you want this document to be binding on your healthcare agent? Let's say you also do a healthcare proxy. To what extent are you saying, I want my healthcare agent to follow this no matter what? And it's interesting, there are different thoughts about this, and that's why it's a very individual process. There are some people, and these are hypothetical situations that have been sort of tested, where some people will say, well, if I specify it in a living will, it's going to take the stress off my family. Or other people will say, well, if I give them as much liberty as possible, then that's going to take the stress off my family. It's interesting. The goal is the same. I'm worried about my family if they're going to be put in this situation, but how you achieve it is different. And again, that could be different from the individual and from the family. I'd also recommend you go to, and I'm not sure if we put this on our website, the American Bar Association has a free, excellent downloadable site, and it actually asks some of the questions and poses some scenarios for you to think about. So I'd strongly recommend that as well. Hope that answered your question.
Great. I had another one, and I will apologize to this person. I'm hoping I'm asking this question right. I think this was also when you all were talking about a healthcare proxy agent and how willing are doctors to take on the responsibility when it comes to that. And Mel, if I did not ask that question correctly, please feel free to correct me.
So is the gist of the question, how willing are doctors to make decisions independently for patients or to become a healthcare agent? I'm not sure. To address the first question, how willing are doctors to just independently make decisions for patients? That's not a comfortable situation for physicians, just as it's not a comfortable situation for patients or for family members. Again, our default and the legal precedent and ethical precedent we have to follow is if the patient's wishes are not known, we will do everything to sustain life unless we feel we're causing an unreasonable burden, we're causing suffering by things we're doing with no hopes of benefit for the patient. If a patient clearly is incapacitated and has no family members, we will go to an ethics committee and help us sort that out. The courts do not like to sort this out. Over the past several decades, the courts have made it very clear they don't want to be in the seat of having to make decisions for patients. I can tell you, though, that in my role as a palliative care doctor, I'll frequently be asked to see a patient in the intensive care unit who's unable to make decisions, the family struggling as to what would be the right decision for the patient, and I'll turn to the patient's primary care physician. And many times, and when I say primary care physician, it may be the cardiologist who has taken care of this patient with heart disease for years, or the oncologist who has treated this patient through cancer-directed therapy for years. And many times I'll speak with those physicians and an outpatient, and they'll say, you know, we haven't had this specific conversation, but over the years I've come to know this patient, and my feeling is this is what the patient would say. And many times I'll then ask that doctor, can I share that with the family? And almost invariably, the physicians will say yes, and please have them call me. So again, I think we're willing to give our recommendations based on what the wishes are, knowing the patient as we do, but to be in that final decision-making situation is very, very difficult for us. Actually, if we have time.
Go ahead.
We do have time. So again, another sort of thing we'll frequently hear is, as a physician, well, what would you do if this was your mother? And the proper answer for me as a doctor is not to answer what my mother would want. The proper answer for me is to say, well, if your mother was the sort of person who always was independent and never would ever want to be in a nursing home or would hate being on machines, this is what I would recommend. It's not the values of my parents that are important. It's the values of what that person is important.
Thank you, Dr. Giokas. And I think too, one of the last things that you had mentioned is how important it is to ask the question, like, what makes life worth living for a certain individual? I know that definitely resonated with me and starting to think about having these conversations. I do just have one more quick question going back to the healthcare proxy agent. Could a person make an adult grandchild their healthcare proxy agent?
Yes, if a healthcare agent can be anyone over the age of 18. Doesn't need to be a family member, but it certainly can. Again, it's someone that you trust, someone that you can have a conversation with about what is most important to you, and who has the qualities we discussed earlier, the qualities of being willing to serve as a healthcare proxy. And that means being accessible to the medical team who will ask questions, and being a decision maker. It means someone who can have a cool head in stressful and emotional times. It means someone who is willing to follow the patient's wishes, not their own. So it certainly can be an adult grandchild, as long as that grandchild meets the basic criteria. Because as you can imagine, when the medical team has to confront the healthcare agent with circumstances and questions about how to proceed, that agent needs to know how to respond, or how to carry out the wishes that they've hopefully had a conversation about with their loved one.
If I can add another, and sometimes terms are confusing. So the person that's named is the healthcare agent. The form on which that document is completed is the healthcare proxy. So the proxy is the form, the person is the healthcare agent. And we don't make it easy for you in our healthcare system, unfortunately. So we also have, if you ever look at a registration sheet, if you've ever been hospitalized or had day surgery, there's a registration sheet. There's the emergency contact. That's not necessarily your healthcare agent. There is the next of kin. That's not necessarily your healthcare agent. And now we have the HIPAA person, the person who you are going to allow to disclose information with. And I can tell you there are many, many times where families will say, well, I'm the HIPAA agent, or I'm the next of kin. That does not necessarily qualify you as the person to make medical decisions in New York State. That's the healthcare agent. The power of attorney in New York State does not include healthcare decisions. So a power of attorney is not legally authorized unless it's added to that document as a designation of a healthcare agent. Power of attorney is not legally authorized just by being the power of attorney to be the decision maker for healthcare issues. And finally, only the patient can designate a healthcare agent. And that's why, as Emily is saying, especially when we're dealing with dementia, that's why it's so important to engage the person early. After that person's lost the ability to make decisions in terms of appointing a healthcare agent, nobody else can appoint a healthcare agent for you. Only you can appoint a healthcare agent.
I'm curious for any panel member, what percentage of the time do you see people not choosing a family member? I often think sometimes a neutral person who's maybe not a family member can be a good choice, because it's difficult for family members to separate those emotional attachments in these situations. But what do you see is most common for people?
I could jump in just because one thing, it's actually interesting you brought that up, because one thing I see a lot is people appointing, at least with my own clients and families, appointing a family member as well as someone who's not a family member in not really a backup, but this is my team of people. I've actually seen that quite a bit, especially lately. Can't really give you a percentage, so I apologize, but more lately than not, I have seen, someone be with their husband for 50 years and say, you know, I just don't think he can make that decision for me. I'd like it to be, you know, my friend who knows me well. So I see that actually with the individuals with dementia and their families quite more often than I had expected.
I've seen too, and I can't give you a percentage, where it's not so much that there's a concern that the family member won't be able to make that decision, but honestly wanting to spare the family of the stress of dealing with the decision. I know a number of professionals, medical professionals, will frequently choose the person they've been practicing with for many years. And again, with the family's permission, and with the input of the family, certainly, because there is, you frequently hear, I'm concerned about the impact this is going to have on my family. And we frequently will hear family members who are the healthcare agents say, I know what my dad wants, for example, but I'm really concerned how this decision is going to affect my family. Is my sister going to be able to live with me if I make this decision? So that's, again, why it's so important to have these discussions early on where this can be shared before the crisis.
And I would offer, and perhaps you guys can comment, that it's one thing to appoint somebody, and then it's another thing, especially if they are a family member or even if they're not, to include everybody in the family in these conversations, because I know even for myself, when my parents appointed my sister as a healthcare proxy, you know, I'm in agreement with that. She's someone who's very close in relation to where they are, and she's readily available for those conversations. But I don't want to feel left out of knowing that, so that in a way I can keep her on task too, to make sure she is fulfilling their wishes. So do you ever experience that within family members?
I get that quite a bit as the social worker on staff here. I do a lot of what I call diffusing the situation. We have family members who their parents have appointed one of the children for whatever reason, whether it be close proximity or like you had said, Kristen, and the other siblings or something that don't agree. And I often say, well, did we have these conversations ahead of time? You know, did mom and dad say, we're appointing this person because we think they'll be able to do this? Or, you know, did we have the conversation of everybody knows what our decisions are and this is how it's going to be? We just have this person to make these decisions. So a lot of times as I'm advising people to make these advanced care planning kind of moves, I say you should have these conversations with every member of the family and know that that shouldn't be a blame game in the end, because it is a touchy subject in terms of, you know, progressive diseases or end of life care. So I have those conversations a lot with my family members.
I'm good. Another sort of segue of this is the medical perspective, is that sometimes there is an assumption that doing everything, one of our slides talked about aggressive care, doing everything, using a feeding tube, attempting resuscitation, putting a person on a mechanical ventilator, putting them through their 4th course of chemotherapy when the cancer has not responded to the first 3 courses of chemotherapy. By doing that, we're doing everything, and that's what mom or dad would have wanted. And I'm using the mom and dad situation, but it's sort of the most common. And sometimes that's it's sort of equated to how we love people. We're going to do everything for you. I think we also have to understand, and hopefully physicians and other medical professionals can help support you in understanding that sometimes doing everything medically, technically, technologically is not always the best thing for the individual and may actually cause more suffering, especially if there's no reasonable likelihood that it's going to get the person better to the way everybody would have wanted. We try to focus on okay, what would the person want? And not in terms of, again, the specific treatments, but to do everything to do what? To be able to live their life how they would want to live their life. And so would going through another round of chemotherapy make that? Or in Emily's situation, a person with advanced end-stage dementia, would a feeding tube really change things, or is the disease only going to progress anyway to a point that mom and dad may not have wanted? So that sense of doing everything is such an emotional tug. And as physicians, we need to advise families that we will do everything to make sure their family members respected and cared for and comfortable and not suffering. But sometimes not doing things is actually the most respectful way to follow a patient's wishes.
I'm just going to kind of bring us back towards a little bit to the beginning of talking about having these conversations, and just pose to the panelists or the speakers just about different challenges that they may have experienced with, not necessarily within your own family, but to have these conversations. I know Gwen, you had showed us a lot of good conversation starters, but I'm guessing that there's a lot of different things that can impact having these open conversations. So if anyone could kind of touch on that a little bit.
Well, I can tell you from my own experience that my own family, even though this is the kind of thing I talk about all the time, they don't want to talk about it. So what I have found is that very short little conversations, 5 minutes long, bringing up the subject, and then segueing into something else completely different is all that my family wants to take at any particular time. Over time, we've gotten to the point where my husband and I were both able to talk about these things and appoint healthcare agents for ourselves, and our children are doing it as well. They're both adults, but this is hard. Having these conversations is not an easy thing. There's that underlying current that we're talking about end of life. We're talking about serious illness. It's not anything that we as people like to think about. But I, for one, don't want the burden of responsibility to land on my family members. So it's very important for me to lay it out for them, so they're just following my wishes. And that's often part of our conversation too. You don't have to make decisions for me. You just need to be my spokesperson. Follow my wishes, and hopefully that will help some of the stress at the time, if the time ever comes where they have to be the very make these decisions and be the sort of on the spot, on the hot seat. I want it all laid out. And so when we're talking about these things, I guess to just recap, short conversations work for my family, and repeating it over and over in different ways multiple times. Because like I said earlier, it plants the seed. They get thinking about things and how it might affect them in their own lives, and their decisions that they might make. And you never know how that seed is going to grow.
If I could just touch on a challenge that came to mind as Gwen was talking, was one of the biggest challenges that I've faced and my family has faced is age. I am under 30, and my family looks at me like I have 3 heads when I say I want to talk about what I want. And we should talk about what you want. And it's interesting enough to me that even family members in my life who are 40s, 50s, going into 60s say, I'm too young to talk about this. It really just circles back to what, Dr. Giokos had said. It's never, too early until it's too late. It really, really should resonate with you, because it's never too early to start talking about these things. And that's why we have systems in place where you can change these things. It's like he said, not a one and done. So it really, age is a big factor. People look at me like I'm crazy when I say you should start talking about these things. Adult children, as they start planning for their parents or other loved ones, that oftentimes that I've seen has struck a conversation in themselves of, I know we're pretty young, but maybe we should talk about these things, because life is very unpredictable, and it doesn't just have to be neurodegenerative disease or any kind of progressive disease for it to really strike that conversation. But it's a big challenge and barrier that I've seen and experienced.
I'm just going to add a couple of things as well, and especially now with COVID and what our country and the world has gone through over the last 2 years, that we realize that, and this can happen. Sudden, horrible illness that's changing your life can happen to anyone. And I think no one's escaped the pictures of people dying on machines, isolated. You can't escape that. Even before COVID, I can't imagine a situation where someone's been so isolated that they haven't had a friend or a family member been so sick where they were been in an ICU at the end of their life, or something suddenly has happened. So to use that as an opportunity to say, again, short and sweet. I like what Gwen said, short and sweet. Listen, I don't want to end up like that. Maybe for a short period of time if you can get me back, but I don't want to be like that. I also like to keep it simple. So for my personal life, I've let my wife, who's my healthcare agent, know that if I can't get a joke, and there's a part on the healthcare proxy where you can add some instructions. So I put, if I can't get a good joke, that's it. And I don't mean if I'm depressed, and I've told her this, if I'm depressed, you can treat depression. But if my brain isn't working where I'm not getting good jokes, that's it. That's it. So think about something that's personal, short and sweet, and share it with your family.
Well, thank you so much, panelists, as we come to the close of this session, and thank you to our audience for your time and being with us today, listening to this wonderful information about these different conversations. Don't delay, start your conversations at home when the time is right, and hopefully the panelists sharing today has impacted you in some way. We do invite you to join us for our next session in our 5 series, which is on Tuesday, November 9th from 3 to 4:30, Facing Serious Illness. And actually, Dr. Giokas will join us again with 2 other panelists for this conversation. And so we invite you back for that. And then our final session on Tuesday, December 7th, from 3 to 4:30, Making Our Way to a Good Death. So the series really has built to the final conclusion, in that we know 2 things are certain, right, panelists? We are born and we die. Everything else in between life is what we make of it. And so with that note, thank you again. Make your wishes known so that you too can be treated in the way that you want to be treated. And we wish everybody a great rest of the evening. Thank you again, panelists, and thank you to everyone for joining us today.